And welcome to the Dr. Bob Show. Have you ever had problems with your shoulder? Does it get a little stiff? Well, boy, mine does sometime. I wonder what the cause is. We'll be spending most of this show talking about shoulder pain, what you can do about it, how to diagnose it. My guest is Dr. Paul Brady. Dr. Brady is a board-certified orthopedic surgeon, but he specializes in arthroscopic shoulder surgery. He'll be answering most of our questions. Hello, I'm Dr. Bob Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking how smoking can damage your heart. But how about breathing in somebody else's smoke? How does it bother your heart and your lungs? And do you have a cough and hoarseness and your asthma is getting worse, or any of those three? Could it be due to a hidden factor? Sure could. And we'll be talking about that. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Paul Brady, board-certified orthopedic surgeon who specializes in arthroscopic shoulder surgery. Paul, welcome to the Dr. Bob Show.
Thank you for having me.
Tell me about arthroscopic shoulder specialist. I thought arthroscopic was knee.
No, arthroscopic means to look inside of a joint. So it could be a shoulder, it could be a knee, it could be a hip. You can look pretty much inside any joint in the body with the small cameras.
So I understand not only are you an arthroscopic shoulder specialist, but you've written a book or two.
I have. I've written 2 books on the subject of shoulder arthroscopy, yes.
And you said very gently they're bestsellers.
Well, yeah, in the orthopedic world, they were bestsellers, which is a big honor to be a part of those books.
Paul, I think that's very, very exciting.
Thank you.
When somebody comes to you with shoulder pain, how do you know if it's going to be rotator cuff or bursa or tendon or separation? Can you have separation of the shoulder?
Absolutely. You can have all of those things you mentioned. And, you know, it all starts with their history and what their injury pattern was. How did they start to have shoulder pain? So that tells me a lot in and of itself. The separation you mentioned, there are different types of separations even. There's AC joint separations.
What's AC mean?
The AC...
Air conditioner?
it does mean that, but let me show you an example. AC is what's called the acromioclavicular joint. So this is a shoulder, this is the shoulder blade, and the arm moves like this. And the AC joint is here on top of the shoulder.
So this is the clavicle.
That's right, the collarbone or the clavicle.
And that's where it hooks up on the outside.
That's correct. It meets this joint called the acromion. Sometimes if you fall on the shoulder, like Sam Bradford did, you can separate the AC joint.
Sam Bradford, now that was an Oklahoma quarterback.
It was, yeah, it was. And he injured his shoulder pretty bad against BYU and separated his AC joint.
So when it's separated, what's the history of that? You fall on it and it hurts.
Typically the history is a fall directly onto what we call the point of the shoulder. So you fall right onto the end of the shoulder, and that tears these ligaments called the corticoclavicular ligaments. And those are the ligaments that are holding things in place. And so if they're torn, that thing is going to stick up in the air, and it looks very abnormal and it hurts.
So how can you fix it?
Well, it's interesting that you ask. This has been a big problem for many years since I've been in orthopedics, because there was never a great way to fix this. And it was a real conundrum, and so I started thinking, and there had to be an easier way. And in fact led me to Home Depot. Okay, so I went to Home Depot, and I just looked in the washer section of Home Depot for some kind of device that maybe I could modify and help to fix this better. And I ended up developing a device called the dog bone implant, which
what's it look like?
I'll show it to you here. It's a very small implant right here.
Oh, that's a little bitty thing. Well, what does it do?
What I do is surgically, I position one of these implants underneath this bone called the coracoid. I place another one on top of this bone called the clavicle, and then I connect the two with suture material, and that holds that bone down. And we tested it and got FDA approval, and it's actually twice as strong as any other construct out there. So it's done very well on the market.
For football players now who have shoulder separation, can you do the dog bone?
You sure can. We've done it with football players, but you can also do it with normal population. Not everybody needs their AC joint fixed. But if they're having symptoms and if they're having continued pain, this is an excellent way to fix it, which has worked very well.
Tell me about rotator cuff, because it seems to me like everybody gets a stiff shoulder and they have a shoulder problem. How do you know if it's a rotator cuff? What is a rotator cuff? And explain that to me.
First, the rotator cuff is a group of muscles. There's 4 muscles that become tendons and they attach to the top of the arm bone. And those 4 muscles together are called the rotator cuff muscles. Okay?
What do they do with the shoulder?
So what they do, as the name would imply, is they rotate the arm. So you rotate, the arm has more motion than any joint in the body. And so
you can throw and
you
can
throw,
catch, you can
it's
grab.
amazing. Guys can throw 100 miles an hour. The only way they can do that is because of all the motion in the shoulder. And it's got more motion than any part of the body, and so it's the rotator cuff muscles that coordinate and allow you to do all those amazing things.
So there are 4 muscles that do it, and they have tendons that make the shoulder wiggle.
That's correct.
So what happens with rotator cuff injuries?
You can have 2 types of injuries with rotator cuff. You can have what we call acute injuries, where bang, you fell or you threw a ball too hard and you injured your rotator cuff, or you tore that tendon off of the bone. Or you can have, which is actually more common, you can have chronic injuries where you just slowly get wear and tear on the tendons, you slowly get increased shoulder pain, and that's probably what I see more often than not.
There are 4 muscles that do that. What happens to those muscles? Why do they tear? What's going on?
Well, as we age, those muscles just naturally get a little weaker with time. You also develop some bone spurs around the shoulder frequently. And so the combination of those 2 things, weakening tendon and some spurs around the shoulder, can lead to these rotator cuff tears.
How do you make the diagnosis? History, you said, what's the history? You talked about the history. How about the physical? What do you find on physical exam?
So the history and physical are the keys. The history I mentioned, and the one thing I did want to mention is that a lot of people have night pain and a lot of people have arm pain. Those are the 2 most common things I see as far as the history goes.
So somebody says, Doc, my shoulder hurts, and at nighttime it's killing me. I can't sleep.
Oh, that's really making me think of rotator cuff problems if they come in with that history. The physical exam is key, and what I do is a series of tests of each of those muscles of the rotator cuff to try to isolate where their problem's coming from. Or maybe it's not a rotator cuff problem, but those tests help me determine that.
So the test will be wiggling the arm a certain way and see where it's weak or what produces pain.
Exactly, that's exactly right.
When you think you know, what X-ray test you get to verify?
So I get some plain X-rays in my office just to look for the bone spurs and to see if they have other problems like arthritis. You can see arthritis real well with X-rays. But the test that you need to get for a rotator cuff diagnosis is an MRI, which stands for magnetic resonance image. And yes, sir.
That's really the one that really gets down to look at the very minuscule part of the rotator cuff.
It's an amazing test that helps us so much as orthopedic surgeons to really make firm diagnosis on patients' problems.
So it can tell you where the tear is on those 4 muscles that you've already figured out on physical exam, but it verifies it and tells you exactly where in that muscle?
It tells you which muscle, it tells you how much of it's torn, you can even deduce some things like how long has it been torn. For example, if you see on an MRI that you have a lot of atrophy, well, that's probably a tear that's been there for a while.
Because atrophy would mean?
Atrophy means that the muscle is kind of withered away,
Yeah,
And if you see that withering away of the muscle on the MRI, well, that suggests that tear has probably been there for a while.
And if it's been there for a short period of time, can you ever do physical therapy that gets it better and you don't have to have surgery even though there's a minor tear?
It's definitely an option, yeah. Physical therapy is a good option for a lot of patients, and so that's where we start for many patients. But some patients, that's not such a good option. If they have a full tear and they're very active, physical therapy is probably not going to work for those patients.
We're talking with Dean Conatser, and Dean, welcome to the Dr. Bob Show.
Thank you.
Tell me about your shoulder. When did you first start having shoulder problems?
I guess when I was in college, probably throwing frisbee, playing sports.
Were you a good frisbee thrower?
I was.
Yeah, and you had a dog that would catch your frisbee?
I did. I had a Weimaraner that was a frisbee expert. He could catch them hanging out in the air if I could throw it long enough, but I think he was one of the best frisbee dogs I'd ever seen.
When you would hurt your shoulder, would it get better and then you'd hurt it again?
Yep, over for 20, 30 years I would injure it and then it would get better and then eventually I would hurt it again, and I went through this cycle many, many times, you know, trying to lift weights or whatever. I would eventually hurt it.
So how bad did it get before you decided, I got to get it fixed?
When I couldn't pick up my arm above and turn the volume on my radio and put it in gear and stuff, I knew I had to do something, and I'd been that way for several months after throwing a cast net and hurting it down on the lake fishing.
Would it hurt you more at nighttime? Did you have difficulty sleeping?
It did bother me at night, particularly hard to sleep. I'd wake up at night, my whole arm would be numb.
When you went to see Dr. Brady and he said, let's fix it, and he fixed it, how was the recovery? How long did it take you before you were ready to rumble?
I did very well, probably within 3 months. I felt pretty good.
Did you work real hard on it with physical
I did.
therapy?
The therapy, I was above and beyond. If they said do 10, I'd do 15, and I did it at least twice a day at home, you know, plus I went to the therapy center, you know, a couple times a week, but I was pretty religious about it.
And Dr. Brady told me he saw you on the lake recently and he was watching you cast and your shoulder was perfect. How's your other shoulder?
My good shoulder is now my bad shoulder.
So the bad shoulder is now, how good is it?
It's, I would say, close to 100%, you know, as far as I can tell, you know, where this one I'd say it's maybe 80.
So the one that hasn't been fixed yet is now your bad shoulder.
Yeah.
It used to be your good. What would be your advice to people that was having shoulder pain and they couldn't move their shoulder and they couldn't sleep at nighttime?
Go see a good doctor and get an MRI, and then they can tell for sure. I wished I'd have done it probably 15 years ago. Would have made life a lot easier for me.
Dean Conatser, it's so nice of you to come to the Dr. Bob Show. You're a great friend of mine and a great fisherman, and it's nice to see you where you've got a good shoulder and you can do what you want.
Well, thank you very much.
We're talking with Dr. Paul Brady, board certified orthopedic surgeon, arthroscopic shoulder surgery specialist. We've been talking about shoulder separation. We're talking about a new little dog bone apparatus, a little bitty apparatus that can fix that shoulder better where it doesn't get loose and re-injure it. And then we started talking about rotator cuff, 4 muscles. The 4 muscles form tendons in the shoulder that let it move around so well. That's why I could throw a baseball so fast. And that those can tear, can be sudden, or it can be where the muscle gets older and sort of dries up and begins to tear. MRI is the best diagnosis. How did I do?
You did perfect.
Now, tell me, when physical therapy didn't work and now we've got to do surgery, what is arthroscopic shoulder surgery like?
Well, arthroscopic shoulder surgery is what we call minimally invasive. You know, the history of shoulder surgery has been big open incisions around the shoulder, and you have to kind of move all the muscles out of the way in order to see inside. Well, the problem with that is a lot of trauma to the shoulder and can really cause a lot of damage before you ever get to the real problem. And so arthroscopic is done totally different. We try to make minimal incisions, very small nicks in the skin. And then,
how big?
oh, usually less than 1/4 of an inch.
Oh, so it's really small.
It's very small.
How
yeah.
many? 2, 3, 8?
Usually about 3 to 4 little nicks in the skin, and then we put the camera inside the shoulder, and we fill the inside of the shoulder full of saline, which is basically water with salt in it.
Now, when you put a camera in, Paul, is that like a fiber optic, or
Yes.
is it a big camera?
No, it's very small. It's actually smaller than a pencil, and so it's fiber optic. Exactly right.
Can that camera wiggle around so you know exactly where you are?
That camera can move all around, and you can move it to the front, the back, and so you can see the shoulder so much better with the arthroscope than you can if you have to make those big incisions.
And the saline opens it up even bigger so you really know where you are. Then what?
Then we use instruments in order to do the repair work. And I describe it to patients like fixing or creating a ship in a bottle. You know, we're using small instruments through teeny holes in order to do repair work on the inside.
When you do that, it's obviously less trauma to the person. There's 4 muscles. You know which one? You know pretty much every shoulder different?
Every shoulder is a little different, but the general anatomy is the same on everybody. All the tears are different. Every tear I see is a little different than the next one, but all the anatomy is pretty similar.
Now, I'm going to ask you what a complete tear, how you fix that in a minute, but what happens if there's just little tears in the muscle group? How do you fix that?
Well, if they're real small tears, sometimes we don't have to fix it. In fact, if it's small, then sometimes just cleaning up the torn edges is all the patient needs to become symptom free, and that's a much easier recovery if that indeed is the case.
If there's a complete tear of one of those tendons of the 4 muscles, muscles have a tendon, they insert into the shoulder. If you tear one completely, how do you fix it?
So what we do is we prepare the bone. The tendon attaches to the bone, right? So we prepare the bone and we roughen up the bone with little instruments, and then we put small screws into the bone. They're little teeny 5mm screws. They have some sutures attached to them though, and so then we can weave those sutures through the tendon, tie everything down, and that secures everything down to the bone.
So how big are the sutures? You tie it down. Are they little mini sutures? Do they stay there? Do they melt away on them by themselves?
They're very small, but they're also incredibly strong. In fact, I can pull them as hard as I can, and I can't break them, even though they're very, very small, and so they don't create a lot of problems inside the joint. Do they ever go away? Probably not. They stay there, but the body just heals around it, and you know, if we ever had to go back, you'd have a hard time ever finding them.
So you fix that tear, you suture it together to the screw that you've got in there, and you fixed it. So then can I go out and play baseball the next day?
Next day, maybe not, but eventually, yes.
And the recovery is much better than if you had to do the real big old surgery.
It's so much better, Dr. Bob. It is easier, it's less painful, it's less scar tissue. It's just a better, easier recovery than the old open surgery for sure.
So let's talk about what you tell the patient after the surgery. You come back and you say, hey, we found the tear, we've sutured it there, you should do very well, but I want you to do the following. What kind of recovery time does the patient expect?
Well, I explain it to him. I try to explain all that beforehand because I don't want any surprises. So what I explain to him, there's kind of 3 phases is what I call it. The first phase is just let them recover. Give them 6 weeks of just relaxing, not doing very much. That's time for that tendon to start to heal. The second phase I call the motion phase, and that's when I want them to work with physical therapy to get that motion back, because they'll start out stiff, everybody does, but slowly but surely they can get that motion back. And then the last phase is the strengthening phase. And that's usually when patients really feel like, all right, now I'm getting a good shoulder back. So, you know, if patients go through those 3 phases and do what I ask them to and what the therapist asks them to, usually they do great after this surgery.
You know, I was talking to a patient of yours named Dean Conatser, and Dean, who's a fisherman, and you saw him fishing. He says, Doc, I can fish, I can do anything I want now. And another person I know, one of my nurses you fix, she can do everything with her shoulder. What's it like for people to come back and say, I couldn't move, I couldn't sleep at nighttime, and now my shoulder's great?
There's nothing better. I mean, you and I both went into this field to help people, right? And that's what I love about orthopedics, is that we get that feedback of patients who, you know, they went from where they couldn't do the activities they love to do. Dean, it's fishing, you know. I mean, he couldn't fish, or actually hurt his shoulder by throwing a cast net, and so he couldn't do those things. And so it's great to see those patients in the grocery store or in the clinic or wherever, and them to really be so excited that they can do what they want to do, and they can sleep, and they can really have a great life because their shoulder feels good again.
It must be a phenomenal feeling. Tell me about arthroscopic surgery for other types of shoulder problems? For instance, let's mention 2 or 3 that you can do. We talked about rotator cuff. What else?
We talked about rotator cuff. I mentioned the AC joint injuries, those separations. Well, sometimes you can get what's called a glenohumeral separation or a dislocation. That's a much bigger deal for most patients. And so that's a thing that we can treat arthroscopically as well. It used to be a big open surgery with a very difficult recovery. It's much easier now. We can treat bone spurs. We can treat...
what do you do with a bone spur? That's an overgrowth of calcium there. Do you just go in there and shave it down?
Exactly what we do. Yeah, we go in there and we trim it off with a little, what we call a burr. It's a teeny arthroscopic burr, but we trim off that bone spur, and that can help patients tremendously.
So you've got the camera, you make the little incisions, you got the camera, you put in the saline, you see it, and then you just smooth out the joint.
Exactly. Yeah. No, that's exactly what we do. And so that's a great thing that really helps patients, just to get those bone spurs out of there.
Paul Brady, you're a wonderful teacher. I can't believe how much you all can do through a little small instrument.
Yeah.
And thank you so much for coming to teach us. People with shoulder pain can know that they can get it fixed without a big scar, and the recovery time's better. Must be fabulous for you to do that.
It is fabulous, and it's always a pleasure to meet with you and to talk to you. I enjoyed it.
Paul, thanks very much.
Thank you.
Wasn't that great? Now you're going to want to stay tuned. We're going to be talking about what happens if you breathe in somebody else's smoke. If they're smoking cigarettes and you breathe it, could it damage your heart? Could it damage your lungs? And what if you have hoarseness and cough and your asthma's getting worse? Could it be due to another silent disease? A lot of information for you. You're going to want to stay tuned. I want to thank Dr. Paul Brady for his wonderful discussion on arthroscopic shoulder surgery. Fabulous. Now for questions from you, the viewer, that I think will be important to your health. Dr. Bob, my husband smokes. Will it damage his heart and lungs? Well, absolutely it will. There's no question. When we smoke cigarettes, nicotine is absorbed into the system. That nicotine can damage the wall of blood vessels. When it does that, then there can be cholesterol that deposits there, and that's hardening of the arteries. If that happens on the arteries that supply the heart, the coronary vessels, then we get hardening of the arteries and plaques in the coronary vessels, setting you up for a heart attack. But let's go a little bit further. When your husband smokes and he blows out that smoke into the rest of the house or into the car, we breathe in secondhand smoke. So you breathe your husband's smoke, or your children breathe that smoke. 400,000 upper respiratory infections every year occur because breathing in somebody else's cigarette smoke. And breathing in somebody else's cigarette smoke can also cause cancer of the lungs. In Italy, the males are the smoker. But when cigarette smoking became prevalent and they looked at houses of smokers versus non-smokers, the women in the houses, the women didn't smoke, in the houses of smokers had a 10-fold incidence of cancer of the lungs. So if anybody that smokes where you are, get them to stop. It's hurting other people's health, not just theirs. Question number 2, Dr. Bob, how dangerous is reflux disease? Let's talk about reflux disease because it is dangerous. Number 1, when we eat food, it goes down to the stomach. Acid begins to digest the food. If that acid begins to reflux up toward the chest or the throat, then you get esophageal reflux disease. It can burn the lining of the throat. It sets somebody up for Barrett's esophagitis, and Barrett's esophagitis can change its lining where it's precancerous. But it does other things that people are not aware of. Reflux at nighttime can come all the way up to the throat, and it can burn the throat, and it can cause hoarseness in the morning. So if you wake up with an acid taste in your mouth, with hoarseness, and the hoarseness gets better as the day goes on, it could be from reflux, and it can be silent reflux. If you've got hoarseness in the morning, it may not be postnasal drainage from allergies, it may be reflux disease. People that have asthma, there are wonderful medicines, But if they don't respond to their medicines, it could be that reflux is causing the problem. Two ways. Number one, when the reflux is in the middle of the esophagus, it sends a message to the lungs that tells the lungs to cough and wheeze. Or the reflux can go all the way up and go down into the lungs, causing burning and irritation and aggravation of asthma. If your asthma is not under control, think about the possibility that reflux is doing that. When people have a chronic cough, one of the things that can cause a chronic cough without clearing their asthma can be reflux disease that goes down into the lungs or sends that message to the lungs to cough. So always think of reflux disease if you've got burning in the middle of the chest, if you've got hoarseness in the morning, or your asthma is getting worse instead of better despite good medicines. Well, that's all the time that we have for this show. I hope you've enjoyed it as much as I have. Remember, we've got to be exercising. If you'll exercise every day, the most important thing you can do, it will relieve stress. You'll really feel better. Runner's high produces endorphins and kephalins, makes you feel better, makes everybody feel better. It will lower your blood pressure. When we exercise and perspire, we get rid of sodium, and that getting rid of the sodium will make blood pressure fall some 8 to 10 points if we exercise regular. It causes collateral circulation, extra circulation in the heart, so it helps prevent heart attacks. It causes an improvement of the lining of the heart. Be sure that you're getting 8 hours of sleep. If you get that sleep, you'll feel so much better. The people around you will feel better. You'll be more productive. Eat good food. You know, we eat improperly in the United States. We eat too much food, and we eat the wrong kind of food. Eat properly, and most of all, what is it we like? It's that laughter in your life. Laugh a lot. You will stay healthy.